A very good morning to everyone. So at the outset, I would like to thank CSI for giving me this opportunity. So today my topic is dry eye workup, what we can basically do it in the basic workup in our routine OPD. So as you can see all these photographs, there are different conditions associated with dry eye. So we need to evaluate dry eye properly so that we can treat these conditions and the dry eye properly in a systematic manner. So when we talk about dry eye, we know that it's basically there are two types of dry eye. One is aqueous deficient, where your tear secretion has gone down, something like your primary Sjogren's or secondary Sjogren's syndrome, or lacrimal gland dysfunction, where the lacrimal gland has been infiltrated by either tumor or there is some other pathology in the lacrimal gland, or sometimes systemic drugs also can cause aqueous deficient dry eye. And the other is the evaporative dry eye, where your tear secretion is normal, but the tears are getting evaporated because of the lipid layer problem or the mucin layer problem. So conditions like MGDs, blepharitis, keratoconjunctivitis, later on the sequelae could be dry eye. The topical drug administrations, especially with the preservatives, allergies, chronic contact lens usage, disorders of the lids, environmental or age factors could lead to evaporative dry eye. So when we do the workup, the first and foremost important thing is your history. History taking is very important. That it gives you a clue about what are you dealing with, or it helps you to rule out few of the things. So history of itching, rubbing, asthma, allergy is important to rule out the VKCs and atopic diseases. You need to ask patient whether they are the chronic contact lens users. Then you need to ask about the profession. That will give you a time whether they are outdoors or more exposed to the wind, or they are indoor and spending a lot of time on the screen. That would cause more evaporation and lead to dry eye. History of any kind of burns or thermal injuries, again very important. And if you feel that these history is not positive, you should also ask patients according to the age, something like a middle-aged woman. You need to ask whether she has small joint pains and all, or you need to ask skin rash or bowel dysfunction to rule out autoimmune disorders. Now once you take this history, again it is very important to take a detailed history what all medicines they are on, because you will be surprised that how many patients who walk in our OPD are actually on antidepressants, and they are actually a culprit for the dry eye problems. So once we are done with the history and we've got few positive histories, note down that and move on to the examination part. Now examination eyelid is the very important thing. As you can see it in these first two photographs, these are the normal eyelid thing, where on this you can see a very nice mucocutaneous junction and the normal meibomian glands. The second photo where the mucocutaneous junction has disturbed and the keratinization has happened, it can happen in SJS, it can happen in OCP or in burns. The third is the MGD, where your meibomian glands are blocked and telangiectasias are there, and you need to even see the eyelashes for any demodex or blepharitis, dandruff kind of a material. Then after that, you need to see the conjunctiva properly, evert the lid, look for the papillae to rule out the weak cases, look for the luster of the conjunctiva, look for any discharge, whether it is there, look for the Bitot spot. Also, always look for the lower fornix for the shortening as well as the symblepharon. That will give you a clue about the OCPs or any other autoimmune disorders. And if you have only a congestion, it could be that patient is on topical drops, something like anti-glaucoma medications. The cornea, again, you need to stain the cornea and see whether the cornea is affected, because it will give you a dry eye related keratopathy idea, as well as you can grade the dry eye, that how severe it is. Also, you will get an idea if you see some old shield ulcer opacities or some old sterile melt opacities, or sometimes like a frank perforation with infiltrate in cases of autoimmune disorders or even in SJS and all. So once we are done with this history and examination, it has to be a thorough. We move on to some tests which we can do it in our routine OPD with our dry eye patient. So the first is Schirmer test, which is very easy to do it. You just need Schirmer strips and the parakin drops and a clock, and basically this measures the tear secretion volume. So it actually will be deficient in your aqueous deficient dry eye. So what you need to do is make sure that patient has not put any drops, has not put any lubricating drops before the test, is not undilated, your fans are not on, your AC blast is not on the patient. Put the Schirmer strips at lateral 1/3, discard that, put another one, because that will still have some reflex secretion, and then measure the value after 5 minutes. With topical anesthesia, that is what we generally do, is less than 5 mm would be abnormal. Then you have this tear meniscus height, which again gives you an idea about tear volume assessment. Very easy to do it on slit lamp. Just stain the patient, make them blink for some time, and you can measure it on the slit lamp like that hack stick types. Or you have these automated machines nowadays which give you a good, which gives you an automatic value. Anything less than 0.3 mm would be abnormal. Sorry. Then there is a tear film breakup time, which will give you the evaluation of the tear film stability. Here, what you need to do is stain it on the slit lamp patient. Tell them to again blink it for few times, then have a complete blink and measure the first dry spot, and that would be your tear film breakup time. You have different machines nowadays which give you. This is a Cirrus which I do it, which will give you the non-invasive one. Then lipid layer assessment. For this, you do need a very good these fancy machines, otherwise you cannot do it. Rest of the tests you can do it just with your slit lamp and the fluorescent strips. If you have it, it's a good idea to know whether your meibomian glands are working well or whether your lipid layer is good. Again, meibography gives you an idea that how many meibomian glands have dropped out. This is a photo which I have taken on Cirrus, and this is the one which you can do it actually on the autorefractometer also. So if you do not even have fancy machines, you can actually evaluate the meibomian glands. Staining, again, very important. Your fluorescent staining, Rose-Wengerl staining is important. It gives you a clue that how is your conjunctiva and cornea affected, and there are different grades which you can use it to grade your dry eye so that it helps in your management. The tear film osmolarity and protein assay, it is, we generally do not do it in our routine OPD workup, so I will not get into the detail. If you have a machine, you can obviously do with it. So in the end, I would conclude that the history and examination is very important whenever you are evaluating the dry eye. The aqueous deficient dry eye will have abnormal Schirmer stress and tear meniscus height. The evaporative dry eye, where the secretion is normal but it's getting evaporated, so your Schirmer may be normal but your T-butt is going to be abnormal, your lipid layer is going to be abnormal, and your meibography you might find some dropped meibomian glands. Rest of the things like staining and all could be abnormal in both the things. The tear osmolarity could be abnormal in both the things. And once you do this basic evaluation according to the cause, you can do the other workup like autoimmune workup if you suspect autoimmune disorder, or you can do even the other tests like serum Ig, vitamin D, vitamin B12 if you are suspecting any kind of allergy or any kind of atopy. Thank you so much.
Thank you, Sheetal, for a